Hi, my name is Connie Klanis and you're watching the video on the optical management of patients with strabismus. And specifically in this video, we'll be talking about patients who are diagnosed with a refractive error, who may also have an ocular motility disorder, and the principles behind when and what we prescribe in this particular cohort of patients. Okay, when we prescribe glasses, we do so to provide optimum visual acuity. We also do this in order to improve the ocular alignment of patients who may have strabismus or manifest strabismus in this context. And for some of these patients who may have a manifest strabismus, the prescribing of glasses can lead to not only a cosmetic outcome, i.e. the eyes looking straight, but also a functional outcome where the patient actually gains binocular single vision from the glasses. So in some contexts, you'll only get an improvement in alignment, so the angle of the deviation will be smaller and less noticeable, and therefore we get a cosmetic outcome. And for other patients, the glasses give them control of the deviation and BSV. It's also worth mentioning at this point that with a latent deviation, you may have a patient who has, as an example, an ease of 4 hour with slow recovery. So a patient who may be breaking down or having some difficulties controlling that latent deviation, and the glasses will assist the patient to control that deviation and therefore gain BSV. In that instance, the patient doesn't have a manifest strabismus, so cosmetically they're fine, but they're struggling to control, and they may be having, for instance, asthenopic symptoms, in which case the glasses will assist in terms of control and relieving symptoms. And finally, another reason why we correct refractive errors in this cohort of patients or our ocular motility patients is that it is a mechanism to treat amblyopia or to contribute to amblyopia treatment. So we all know that two types of amblyopia are anisometropic amblyopia and ametropic amblyopia. So for anisometropic amblyopia, we would be interested in correcting that refractive error to improve the visual acuity and also manage amblyopia. And then we have the ametropic amblyopes who have high hypermetropia. And of course, part of the treatment of these patients will be prescribing the hypermetropic correction. We'll talk more about that when we come to the management of amblyopes. Now, in order to understand the rationale behind why we prescribe what we prescribe in patients with ocular motility disorders, we need to go back to the relationship between accommodation and divergence or convergence. And we know that the more a patient accommodates, the more we have convergence or accommodative convergence. So then we need to think about what lens will induce more accommodation and what lens reduces accommodation. And this you know as well. We know that a plus lens, so a lens that we give to a hypermetropic patient, will relax accommodation versus a minus lens, which we give to myopic patients, induces accommodation. So when we're prescribing glasses, we need to have the relationship between the lenses and accommodative convergence at the forefront of our minds, because that will allow us to understand what its impact will be on strabismus. Okay, let's talk about a patient with strabismus. Here we have a patient with an esotropia and a patient with an exotropia. Let's start off with the patient with an esotropia. Let's think of two scenarios. One scenario where this patient is hypermetropic and another where they're myopic. If they're hypermetropic and I give this patient plus lenses, it will relax their accommodation. And therefore, it's possible that we will see that esotropia reduce in size as we reduce accommodative convergence. The other possibility, if they are myopic, if I give a myopic prescription to this patient, the ET is potentially going to become worse because as a myopic patient, they won't utilize as much accommodation. And then when I introduce the minus lens, the patient will accommodate more, thereby making that ESO worse. So in an ESO deviation, the hypermetropic correction assists the strabismus and the myopic correction makes it worse. So we expect that it's going to be the opposite, don't we, for the exotrope? Here we have the exotrope. Let's say they were hypermetropic. Well, if they're hypermetropic, giving them the glasses will relax their accommodation and the exo will be worse. If they were myopic, then the patient will accommodate more, and with that accommodation will come more accommodative convergence and the exo will be better. Okay, so we can see here that when we're prescribing refractive correction in these patients with ESO or exo deviations, we need to consider the potential impact of that refractive correction on the strabismus. Will it improve or will it make it worse? I'll also make a point just below here about bifocals. We rarely prescribe bifocals in strabismus patients, but we do for a specific cohort of patients with a diagnosis of a convergence excess esotropia with a high ACA ratio. We'll talk about that more when we do ESO deviations, but I'll just make the point that a bifocal, you're well aware, is used at near. So what we're essentially doing at that point is relaxing accommodation even further at near. So bifocals are for patients who have a larger esotropia at near and you want to relax their accommodation to gain control at that distance. Again, we'll come back to that. It's rarely prescribed, but you need to have an understanding of what the relationship is, again, of giving a bifocal in the context of a patient with a strabismus. Now let's move more specifically about how much we should prescribe in particular contexts. There's several possibilities we have here. One is we could leave the patient uncorrected. So let's say, for example, we find that the patient has 2 Dopplers for hypermetropia in both eyes. We have the option of not prescribing that at all if we wish to do so. We could fully correct, which means giving that +2. We could undercorrect, which means we might give half of the prescription +1. Or we could overcorrect, where you would give more than the +2 that you originally found. Now, a point about overcorrection, we don't generally overcorrect hypermetropes. The only overcorrection that really happens is if you give a bifocal segment, but you don't want to overcorrect a hypermetrope because you will be pushing them into hypoaccommodation, and generally it's not well tolerated. So the only time we consider overcorrection is really in the presence of myopia. So when we're considering what we're going to prescribe, these are the 4 options we essentially have. Okay, so let's look now at what we consider. First thing we consider is the age of the patient and what we expect of their refractive error at that age. If we look at infants as an example, most infants, not all, but most, are expected to be hypermetropic. So if you have an infant who is +2 OU, so both eyes are hypermetropic, then that fits within the normal range of what to expect in that infant. And so this is one of those possibilities where you consider not correcting and instead watching that refractive error and looking for emmetropization. Because as you recall, we're expecting that eye to grow in axial length and the hypermetropia to reduce over time. Now, if we decided to fully correct an infant who we found had +2, there is the argument that when you fully correct a hypermetropic infant, you may be stopping or preventing the normal emmetropization process. It is thought that the blur that is induced from being hypermetropic and that accommodation that is driven by the blur is also a driver for emmetropization. So should you go and correct or fully correct this patient, you may be risking the possibility of that child or infant emmetropizing. So once you've considered the age, and if you find that the refractive error is above what you expect of that age, then we start to think about, okay, what is the direction of the deviation and what should I prescribe? Let's start off with patients who have an ESO deviation. I've listed here some general principles about what we should do in the presence of an esotropia. Let's start off with a patient who's been found to be hypermetropic. What do we do in this instance? If the patient has a constant deviation, so a deviation that's there always or a manifest deviation that's there always, then it is best that you fully correct the refractive error. So as an example, if we find plus 3 OU, then you give plus 3 OU. Okay, what we're wanting to do there is we're trying to relax the accommodation as much as possible by giving full prescription and then seeing whether that impacts on the ESO deviation. The full prescription may have an impact on the strabismus, it may not. For those that it does have an impact on, it could potentially make the eye straight and give the patient BSV. Then we have the patients who have an intermittent deviation, those who are sometimes controlled versus other times they become manifest. So sometimes they've got esophoria, sometimes they've got an esotropia. What do you do in this instance? Well, if it's mostly an esotropia, so let's say 80% of the time it's esotropic or the patient has an esotropia, with 20% of the time they're esophoric, well, treat them as if they were constant. Give them the full correction. The issue is when you have an intermittent patient who is 80% of the time controlled, so an esophoria, but occasionally breaks down to being a manifest deviation. And in those instances, obviously they're esotropic. What do you do now? Well, 80% of the time, they're controlling an ESO deviation. They have BSV 80% of the time. What you don't want to do in this instance is then give them a full prescription of hypermetropia, which means that with the glasses on, if they're wearing them all the time, there is no need for them to control any deviation. The glasses will do all the work. And what will happen is the next time they come into your clinic, they'll probably be straight with glasses on, but when your glasses come off, they'll be 90 or 100% of the time manifest. So what you've done to some extent is you've made the situation worse. You had a patient who knew how to control their deviation 80% of the time, and now by giving them full prescription, the patient is no longer required to control the deviation and has lost the knack of utilising their relative fusion divergences to take control of the deviation. So in this instance, what you really want to do is leave them undercorrected. So say we had a patient with plus 3 hypermetropia in both eyes, then rather than giving them all the plus 3, give them something less. Leave them a little bit hypermetropic, so they need to still utilise their relative fusion divergences to control the deviation. The question then becomes, how much do you undercorrect a patient by? Now, if I had a room of orthoptists together and ophthalmologists, you may get variations in answers here. There is no golden rule as to how much to undercorrect a patient by. What you want to do is undercorrect by an amount that the patient is comfortable with. And so a patient can be left one diopter hypermetropic and will be comfortable with that. Will be able to see clearly because they can accommodate one diopter fairly easily and see clearly. Then you've got 2 diopters, patients are fine with that also. 3 diopters is probably your maximum undercorrection. So this is starting to get a little bit tougher for your patient to see clearly. So think about what amount of undercorrection can a patient comfortably see through clearly and potentially maintain BSV when you decide to undercorrect. Okay, and lastly we have the esotropic patient who might be myopic. In this particular instance, obviously what we want to do is undercorrect because we don't want the patient to accommodate more than they need to. Okay, let's now discuss the principles in an exotropic patient. If we have a patient with hypermetropia and an exotropia, well, we know that the hypermetropic correction is going to make an exo deviation worse, so we always want to undercorrect the hypermetrope who has an exotropia. Now, if your patient is myopic, in this instance, we fully correct the patient because we want to get the patient accommodating as normally as possible and forcing some more accommodative convergence to take control of the exo deviation. Now, in this instance, we can also consider overcorrecting the myopia. So if, for example, the patient had 2 diopters of myopia in both eyes, then we could give -3, -4, etc. How much can you overcorrect myopia before you start really impacting on visual acuity? We found that generally patients will tolerate probably up to about -3 overcorrection, and then beyond that it becomes quite difficult for them to see clearly. Again, here you're trying to find the balance between the overcorrection in the myopia and the gaining of BSV. And always what you want to do in this instance is give the patient the least amount of overcorrection that gives the patient BSV. So if again we go back to the example where a patient has 2 diopters of myopia, if the 2 diopters full correction does not give the patient BSV, then this is where we start to look at, okay, let's consider overcorrection. So in clinic, you might then put a 250, -250 in front of the patient, see if the patient gains control of that exodeviation with 250. If not, then go to 3 diopters and so on and so forth. And then you just give the least amount of overcorrection that the patient achieves BSV. So if it only takes an extra half a diopter to give your patient BSV and stereopsis and so forth, then that's what you give. You only give a half a diopter extra. And so what you'll be looking for as you're overcorrecting is the maintenance of visual acuity and the gaining of BSV. Okay, now what do we do when we find a patient has astigmatism or an isometropia? Let's start off with astigmatism. In infants and young children who have astigmatism, patients need to have about 2 diopters worth of astigmatism before we generally consider correcting the astigmatism. Now, in the presence of astigmatism, what I do is, if I'm going to correct the patient, if they have, for instance, 1 diopter of astigmatism, I may not prescribe it, but in order to determine what refractive correction I give the patient, I will alter the refractive error into the spherical equivalent, and I will be prescribing the spherical equivalent, and if I undercorrect, I'll undercorrect from the spherical equivalent. So if, an example, I have a patient with +2 over -1, the spherical equivalence of that is +150, and so I work with that for correcting the patient. If I want to fully correct them, I give them +150. If I want to undercorrect, I go from there. Okay, now let's move on to anisometropia. What do you do when you find a patient has significant anisometropia? So let's say, as an example, we have a patient who has a right eye with +2 diopters of hypermetropia and a left eye with +5 diopters of hypermetropia. Here we have 3 diopters of anisometropia. In children, you do not need to be concerned about the anisometropia, anisoconia, etc. You can prescribe the full prescription and the patient won't be symptomatic. You don't need to create a balance like you do in adults. Okay, let's talk more about maintaining this anisometropic difference and why it's important in young children who are at risk of amblyopia to maintain the anisometropic difference. So here is the right eye and here is the left eye, a bit different to the way I do projection diagrams. And I haven't drawn the hypermetropic eyes as they should be, like one shorter than the other. But what I want you to focus on is the fact that this eye is 2 diopters uncorrected, so it has 2 diopters of hypermetropia. And this eye is 5 diopters uncorrected, has 5 diopters of hypermetropia. Okay, so one of our options is to prescribe the full prescription, +2 and +5, and bring the images onto the retina. In prescribing +2 and +5, we maintain the anisometropic difference. And by fully correcting it, what we've done is we haven't favoured one eye over the other. The image falling on the retina should be as clear from the right eye as from the left eye as it is processed by the cortex. Now let's look at the possibility that we want to undercorrect the refractive error. So they might have an exodeviation, in which case I want to undercorrect, or they might have an intermittent esotropia, so I want to undercorrect this patient. Okay, what we need to do when we undercorrect a patient who has an isometropia is we need to undercorrect each eye by the same amount. So here, this eye has now got a planar, which means I've reduced it by 2 diopters. And this eye, I've reduced it by 2 diopters and I've given them 3. What that means is that both eyes are left 2 diopters uncorrected. And so again, the quality of the image that the brain is receiving to process is equal, and the patient doesn't need to favour one eye over the other. If you also have a look at the difference between the lenses, the plano and the +3, I've maintained the anisometropic difference, so to speak. What would happen if I didn't symmetrically undercorrect the refractive error? Now here we have a plano lens prescribed to the right eye and a +4 diopter lens prescribed to the left eye. So here we have an undercorrection of 2 diopters and here an undercorrection of 1. So we haven't done a symmetrical undercorrection, it's asymmetrical, with more undercorrection for the right versus the left. Which also means that this eye is undercorrected by 2 and this is 1. So the quality of the image that the brain needs to process is now better for the left eye as compared to the right eye. And what we're doing is we're forcing one eye to be favoured over the other. In this instance, the left eye will be favoured. And in doing this, potentially you could create amblyopia. In this particular example, however, the left eye is likely to be the amblyopic eye, and favouring or doing anything that favours the left eye could be an advantage. So unless this is actually the aim of what you're doing, you're trying to get the patient to favour one eye over the other through asymmetrical undercorrection, then that's fine. You're otherwise potentially creating an amblyogenic situation where one eye will be favoured over the other and you could end up with amblyopia that you didn't intend to induce. And coming back to this concept here that I have of maintaining an isometropic difference, again, if we look here now, the plano and the +4, what we see is that there is now 4 diopters of difference between those 2 lenses. And remember that this patient initially had 3 diopters of an iso. So in doing that asymmetrical undercorrection, we now find that the lenses, or the difference between the lenses, is different, which is what, again, is creating a favouring of one eye over the other. Before we conclude, I just want to bring your attention to the AAO guidelines for optical management. The American Academy of Ophthalmology has come up with guidelines of how to manage infants and young children with refractive errors, either in the presence or absence of strabismus. Now, you don't need to learn these off by heart or be managing your patients according to these AAO guidelines. I just want you to utilise the principles we've talked about so far. But I think it is worth noting that there are guidelines available and that these guidelines are not based on evidence in terms of the science of looking at which patients benefit from an undercorrection, of no correction, etc. There is literature out there on this matter, but it's not of high level evidence. So, for instance, systematic reviews or randomised controlled trials. These AAO guidelines are actually based on a consensus between a number of ophthalmologists, and I believe it was something like about 8 ophthalmologists that came up with these guidelines in America. So you can imagine that between orthoptists and ophthalmologists managing refractive errors, it will vary between individuals. And not everyone will follow these guidelines and will have their own principles that they work from based on their training and based on their experience of managing patients. What's worth noting or looking at here is the differences between managing patients with strabismus versus those without strabismus. So you can see, for instance, here that a hypermetrope with no manifest strabismus is left uncorrected with much higher refractive errors than one with strabismus. So bear in mind that there are some guidelines. You don't need to utilise these guidelines. I prefer that you think about the principles that we've talked about and manage the patient according to those principles. But it does give you a bit of a sense of where the thresholds lie for when to leave a patient uncorrected versus when to correct them. Again, the thresholds will differ between clinicians, but it gives you a little bit of a guide as to what to expect. Okay, that brings us to the conclusion of this video. Thank you for watching.